Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Bashar, and today I'm going to review histology, pathology and immunology for week 1 and 2 CVS. يلا بسم الله نبدأ، وإذا استفدتوا تذكرونا بدعوة حلوة. Starting with histology, guys, all blood vessels have these three important structures موجودين بالبلد wall: tunica, antima, media وadventitia. تمام? Except capillaries. Now from the picture, if you want to compare arteries versus veins, we will find that the artery have narrow lumen, very thick wall, and what is the thickest layer? Tunica media, as we can appreciate here. Comparing it to the veins have very large lumen and very thin wall. Okay, what is the thickest layer? هتكون tunica adventitia, as we can appreciate here. تمام. Moving on, now we'll discuss each layer. What is the important stuff بكل layer. تمام. A tunica antima have 3 layers: endothelium, subendothelium, internal elastic artery. Endothelium عبارة عن simple squamous with a basement membrane, very simple. But it's very important for the function. What is the function of the endothelium? 1. Protection. تاني شغلة which is very very important اللي هو anti-thrombogenic effect. شو يعني؟ Basically it will have proteins that will prevent any clot from forming. يعني هيك it will give a sign not allowed to stick here. No, not allowed to stick for the platelets, so no adhesion للplatelets, no adhesion للleukocytes, no adhesion to anything. Okay, فبالتالي the blood will يعني flow smoothly. Okay, because of the endothelium. Moving on to the subendothelium, and I remember subendothelium with a CC, so it have loose connective tissue, plus it have collagen inside it. Okay. And if it was exposed هيصير في عنا thrombus formation. Now for the internal elastic lamina, the internal elastic lamina basically هي عبارة عن elastic bands and they are connected like this. تمام. So they are not fused with each other. فبالتالي it will give us like a fenestrated membrane. تمام، يعني هتعطينا إيحاء fenestrated membrane because إنه هي هيك it's connected in that way. مش هيك، يعني it's not a continuous membrane and it's composed of elastic bands. تمام. هلا خلصنا. we are done with the tunica antima. Moving on to the tunica media. So we remember the media في إلها main contents. تمام، اللي هن 1 smooth muscle, 2 elastic fibers and 3 collagen fibers. okay, و eventually آخر شي رح نشوف external elastic lamina. so معناتها شو عنا smooth muscle, elastic و collagen، و depending on the place يعني حسب المكان كل وحدة بتكون varies in the amount. so مثلا بالmuscular arteries رح يكون في عنا more smooth muscle و we'll talk about this. بالاlastic arteries we'll have more elastic fiber in the tunica media. تمام. so we remember tunica media have 3 things: elastic, أول شي smooth muscle، تاني شي elastic fiber و collagen fibers، و depending on the place. Moving on, what's important بالtunica media basically شيء اسمه vasoreactivity. so لما smooth muscles contract فهذا الشيء بيؤدي لأنه the blood vessel will constrict، فرح يصير في عنا vasoconstriction. if the smooth muscle relaxed فبالتالي هذا يعمل لنا blood vessel dilation، فرح يصير في عنا vasodilation. okay. now for the external elastic lamina it's the same thing، نفس internal elastic lamina بس difference هو بالplace. Moving on to the last layer, tunica externa بقلبها vasa vasorum و nervi vasorum. Vasa vasorum from the name, the vessel of the vessel. So رح تعطي nourishment last layer, tunica adventitia. Okay. Now this is very 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 important. Let's do a revision. We have أول شيء tunica antima، بعدين عنا tunica media, and we have then and we have the tunica adventitia. So between the antima and the media, what's the thing that will separate them? Internal elastic lamina. okay, internal elastic lamina. وbetween الميديا والadventitia, what's the thing that will separate them? external elastic lamina. so always remember this, guys. تمام. so between الميديا والadventitia, what's the thing that separate them? external elastic lamina. وانتما media, internal elastic lamina. very important, very very important. تمام. so you understand what very important means home. now moving on to the arteries. هلا نحن حكينا على general structure of the blood vessel. we will move on to the specific. we will move on to نعمل differentiation between the different types of arteries and the veins. okay. now the artery we have 3 اللي هن we have 3 types of arteries: elastic, muscular, arterioles. okay. so for the elastic it's very important when بيكون in the large blood vessels such as the aorta. why? because the heart it will pump يعني very high blood pressure. هيكون blood contain very very high pressure، فبالتالي we need the vessel to accumulate this pressure so it can stretch and recoil easily. فبالتالي we have the elastic arteries موجودين بالlarge vessels. Moving on to the muscular بنسميها medium sized arteries مثلا مثل femoral artery, radial artery, and lastly the arterioles. The arterioles are the smallest artery and they are called the resistant artery, and this is more focused يعني بالphysiology. We can see this discussed أكتر بالphysiology, resistant artery, why it's resistant إلى آخره. Now I'm gonna focus on the histology point of view اللي هو we'll discuss each one tunica intima, media, externa, and how it's differentiated between each layer. So هي a very quick tip. Okay, elastic وmuscular the only difference هيكون بالميديا. بالانتما والاكسترنا they are the same. تمام. الارتريولز مختلفة تماما. So what I'm gonna do, I'm gonna discuss هيك. Okay, يعني I'm gonna compare each one with each artery. Now for the elastic muscular, both of them they have a very perfect endothelium, subendothelium, as we discussed here. كل layers موجودين endothelium, subendothelium. بس they have no internal elastic lamina. Okay, no internal elastic lamina. هلا for the arterioles الendothelium is thin because they are the small arteries. Arterioles mean they are small arteries, okay, and but they have internal elastic lamina will be present there. Moving on to the tunica media. هلا for the elastic وmuscular هون رح نشوف differentiation. تمام. For the elastic من اسمها it contain more elastic fibers as we discussed بالtunica media. شو قلنا حسب المكان. فبالتالي in the elastic artery أكتر شيء رح يكون elastic fibers and it is very thick. يعني once you see a picture that have a very thick tunica media فورا this is elastic artery. Okay, now for the muscular it contain أكتر شيء smooth muscles و external elastic lamina will be visible. I can appreciate the external elastic lamina. تمام. بس هون not that much, so we will see this and we will discuss it in the picture. Tunica media 1 to 5 layers of smooth muscles and some elastic هيكون عنا it's very thin. Now for the tunica externa معناتها عنا between elastic والmuscular the same collagen fiber vasovasorum. Okay, مثل ما حكينا هون it contain vasovasorum nervovasorum. tunica externa هون رح يكون collagen fiber are longitudinal. معناتها بالارتري الكولاجين فايبر وين بريزنت mainly بالتونيكا ادفانتيشيا. اوكي تمام. هلا هون رح نعمل هيك يعني I don't know بس مثلا رح نعمل هون هيك very quick revision. in the elastic الانتما I'm gonna pause هيك for 1 second وانتوا راجعوا معي. in the elastic الانتما هل الانترنال elastic lamina present؟ no it's not present. طيب هل الميديا what is the thickest layer؟ يعني what is the أكتر شيء رح يكون dominant؟ elastic fibers. برافو عليكم. وبلس هلا عنا الاكسترنال ادفانتيشي بقلبها الكولاجين فايبر زائد شو؟ ايوه اللي هو الفازوفيزورم. moving on to the muscular. هل الماسكولار الانترنال بالانتما تونيكا انتما هل الانترنال الاستيك لامينا present؟ not present. برافو. والميديا what is the thickest thing that will be present؟ اللي هي smooth muscle plus شو كمان شيء شغلة it will be هيك very visible external elastic lamina. اوكي تمام. وهلا عنا الادفانتيشيا اللي هي اللاست لاير نفس الالاستيك اللي هو الكولاجين فايبر بلس الفازوفيزورم. now for the arterioles بس شغلة كتير مهمة اللي هو in the tunica intima شو اللي رح يكون present؟ هل internal elastic lamina will be present ولا لا؟ yes it would be present. هل بالتونيكا ميديا وبالتونيكا ادفانتيشيا very easy. اوكي طيب moving on. هون هي البيكتشر كتير حلوة عم يعملوا لنا مقارنة بين المسكولار والإلاستيك artery. so basically هون we can appreciate guys إنه نحن مثل ما قلنا المسكولار والإلاستيك التونيكا انتما والتونيكا adventitia both of them are the same. بس what's the difference in the tunica media؟ so the most abundant thing that will be in the muscular اللي هو smooth muscle from the name. فبالتالي smooth muscle fibers will be very abundant and what's visible in external elastic lamina will be very visible. okay أما comparing it to the elastic fibers bands will be more abundant in the tunica media. والexternal elastic lamina guys يعني من كتر ما في أصلا elastic fibers يعني we will not be able to appreciate or differentiate it. عرفتوا؟ فبالتالي لهيك قلنا very important إنه نعرف إنه external elastic lamina will be very visible in the muscular arteries. now this is what شوفوا هون عنا internal elastic lamina وهون external elastic lamina visible معناتها this is muscular arteries. برافو عليكم. أنا عم بعتقد إن هلا أنتم عم تجاوبوا إن شاء الله يعني إن شاء الله يا رب إنه هيك تكون عم تتفاعلوا. now here عنا comparison. تمام. فأنتوا هون you can see هون this is internal elastic lamina and this is external elastic lamina وهون smooth muscles are very abundant. this is what muscular artery. برافو. and here you can appreciate that it is very thick tunica media very thick tunica media plus elastic are very abundant. هيك معناتها this is elastic artery. تمام. moving on. هوني رح نشوف الفينز. يعني شو المقارنة بين الارتريز والفينز. الفينز very easy. basically الفين التونيكا انتما هتكون thin والسب endothelial thin. التونيكا media we will have a collagen fiber in the tunica media plus it will be thin. والتونيكا externa هيكون فيها smooth muscles and they are longitudinal it will be very thick as we said from the beginning إنه the tunica adventitia هتكون the thickest layer in the vein. ونحن هون we can appreciate in the tunica media collagen fiber are present. تمام. أما هنيك بالارتريز الكولاجين فايبر وين كانوا more present in the adventitia اللي هو الاكسترنال. يعني نفس الشيء external adventitia. فهون you can see the vein. تمام. شوفوا كيف التونيكا adventitia is very thick. أما هون بالارتري tunica media is the thickest layer. تمام. moving on to the capillaries. الكابيلاريز هي عبارة عن endothelium و basement membrane مو مثل الباقي البلود vessels. why? because الكابيلاريز بصير في عنا الاكسشينج تبع الأو2 والنيوترينز والآخري. فبالتالي I needed to be efficient للفانكشن تبعه. فلهيك I need a very very thin wall. تمام. I have 3 types of capillaries. make sure that you differentiate between them. عندنا continuous, fenestrated والsinusoid. So the continuous اللي هو this is a mnemonic that was done by شاد معتز جزاه الله كل الخير. it's very helpful. الكابيلاريز as we said إنه هو عبارة عن endothelium with a basement membrane and it is الendothelium نفسه will be held by a tight junctions والperiocyte will be between الendothelium and the basement membrane. okay, this is a very هيك general definition على الكابيلاريز. وقلنا في عنا types continuous, fenestrated وsinusoid. هلا now let's see مثلا continuous capillaries وين بتكون موجودة in our body. بتكون موجودة بالمسل باللنجز وبالCNS. so this is the mnemonic my love C اللي هو بالمسل وباللنجز وبالCNS. and I always remember okay this mnemonic my love C دائما إنه C معناته continuous capillaries عشان تعرفوا you link the mnemonic with the capillary with the type. how it's continuous يعني هيكون البيز اللامنا continuous وهيكون الendothelium that is inside it not fenestrated. okay, moving on to the fenestrated هتكون by this mnemonic اللي هو GG كيف اللي هو GIT gallbladder kidneys و endocrine. and what is يعني كيف الشيب تبع الكابيلاري how it will be fenestrated. هيكون الendothelium itself fenestrated والبيز اللامنا will be continuous. okay, now for the sinusoids أهم شي عنا بالبون مارو بالليفر بالليمفويد and the spleen. and البيز اللامنا هيكون discontinuous as it's appreciated هون والendothelium هيكون fenestrated. okay, so guys يعني very important to know which type of capillary موجود بالorgans. فمعناته الcontinuous حكينا mnemonic الfenestrated you remember جيجي كيف and sinusoids بلس فنهايتها S فsinusoid وهون نهايتها C فcontinuous. معناته شو الباقي this mnemonic fenestrated. okay, لأنه أنا مثلا بالامتحان كنت أكتب بلس and I don't know يعني I forgot which type of capillary. فلهيك always link it. okay, which type this mnemonic معناتها هذا type of capillary. moving on now this is the last part of the histology and again I'm not explaining everything. I'm focusing on what's very important for the mid unit and for the exam. وإن شاء الله يعني يا رب إنه يعني this is very quick review. okay, for cardiac muscle tissues the histology of the cardiac muscle tissue basically how to compare it or how to differentiate it between the normal muscle tissue. فنحن عنا you need to look for three things. okay, أول شيء المسل tissue it have striations but the nuclei okay رح يكون 1 or 2 nuclei plus it will be centrally located. تمام. هي واحد. اثنين you will have intercalated disc اللي مثل هدول present. okay, so when you see this cardiac muscle tissue okay you suspect plus there is a branching بيكون بالcardiac muscle tissue. فبتشوف okay it has striations. هلا this photo is not very clear بس from the slides we can appreciate إنه you will be able to see intercalated disc هيك يكونوا lines. why intercalated disc are important لأنه يعملوا لنا cell to cell communication. moving on to the اللي هو heart wall. okay, the wall of the heart we have 3 layers epicardium, myocardium, endocardium. What I need you to really know and really know focus on these 2 important points. The epicardium is يعني it will contain coronary vessels and fat cells. okay, so مثلا the question could come إنه which type or مثلا which layer will coronary vessels will be appreciated. okay. So you need to know in الابيكارديوم will have the coronary vessels و fat cells. أما بالendocardium very 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 important to know that it lines in chambers and it will cover the valve of the heart. So it's very important to know إنه الendocardium رح يكون continuous مع valve of the heart plus Purkinje fibers will be present. طب what are Purkinje fibers؟ هن عبارة عن modified cardiac muscles, okay. They are important for the conduction, يعني it's more related to physiology, بس نحن we need to focus on histology point of view. فالبركنجي fibers as we can see هون مثلا السيتوبلازم رح يكون أول شي رح يكونوا very big يعني مقارنة بالمسل fibers، فرح يكونوا very huge، والنيوكليا هيكون هيك prominent مبين، والسيتوبلازم هيكون pale a little bit pale from the center. And very 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 important to know that they have large amounts of glycogen when in the perinuclear region, okay. So remember link Purkinje fiber مع large amount of glycogen in perinuclear regions. Now moving on to pathology, I'm going to discuss two lectures, hemodynamics with disease of blood vessel, and this is going to be question based. These questions are not to test your knowledge, بالعكس is to gain knowledge. So what I'm gonna do, I'm going to read the question, read the answer, pause for 1 to 2 seconds, and then after that we are going to discuss the question inshallah in a proper way. Bismillah, نبدأ again. Which of the following best explains why fluid normally does not accumulate in the interstitial space? هل capillary hydrostatic pressure always exceeds the osmotic pressure? Plasma colloid osmotic pressure balances the capillary hydrostatic pressure, or fluid movement is controlled only by hydrostatic pressure, or lymphatic drainage is inactive at rest? So what do you think? Okay, so the correct answer is B. Plasma colloid osmotic pressure balances the capillary hydrostatic pressure. And if you want to answer this question properly, خلينا we understand the basics, we understand what is colloid osmotic pressure, what's capillary hydrostatic pressure, علشان we really understand what does that mean. So going back to the question, which of the following best explains why fluid normally does not accumulate in the interstitial space? So normally we don't have accumulation, تمام. If there is any accumulation, it is called edema. Abnormal accumulation of fluid in the interstitial space, this is called edema. For why normally in our body we don't have edema? Because the plasma colloid osmotic pressure balances the capillary hydrostatic pressure. And so let's go back to the basics to understand each one or compare between them. So in our body, the fluid will be distributed into two compartments. Inside the cell, intracellularly, which is the majority of the fluid will be there, or extracellularly, اللي هو outside the cell. And outside the cell هيكون في عنا يعني the fluid will be divided into two spaces, interstitial space and intravascular space. Interstitial space, intravascular space, هون it's very important to know that fluid movement will be here. طب why this fluid movement رح تكون هون؟ هيك هيكون في عنا fluid movement. Why? Because we have two opposite forces. مين هن يا ترى؟ colloid و hydrostatic pressure. So again, this is normally why edema don't happen, because of these two opposite forces that is responsible for the fluid movement in the extracellular space between the interstitial space and the intravascular space. فهون رح يكون في عنا fluid movement, okay? طيب هلا let's differentiate between them. Hydrostatic pressure basically is the pressure that will be produced by the blood inside the blood vessel. يعني هو the blood it have its own pressure عم يمشي, so this is hydrostatic pressure. So think about this, that the blood is moving, okay, we have هون capillaries, it's fenestrated يعني فيها فتحات. فأول ما يعني أول ما تلاقي هون there is fenestrations فورا what will happen إنه يصير في عنا outflow, outflow. So the fluid will go outside to the interstitial space, from the intravascular to the interstitial, okay? And this is mainly will exceed in the arterial end. So I did this علشان we always remember the hydrostatics with a T معناتها it would be exceeding in the arterial end, and outflow will happen, and it's mainly produced by what? By the pressure inside the blood vessel, okay? By the blood pressure inside the blood vessel. Now for the oncotic, معناتها this pressure خلصنا منه, مسؤول على ال outflow of the fluid. So we have الoncotic pressure أنا دائما بحطه الكيورد تبعنا اللي هو الالبيومين, okay? So الoncotic pressure اللي هو الكولويد osmotic نفس الشيء, هذا الالبيومين هي الكيورد تبعنا. So عبارة عن the pressure that will be created by the plasma proteins اللي هي mainly الالبيومين, okay? فشو اللي بيصير basically أنا هون عندي مو الفلويد كلياته هيطلع out flow. what will happen إنه what will be remained اللي هو mainly البلازما بروتينز و mainly الألبومين. فرح يكون في عنا very high solute concentration اللي هو very high osmolarity. so what will happen is that this will make the fluid pulled in, هيخلي الفلويد to bring back in علشان الأوزمولاريتي be balanced. okay so think about this مثل نحن عندنا كاسة وبقلبها مي وملح، والملح is very 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 high in concentration، كتير ال concentration تبع الملح عالي. what we can do is add a little bit of water علشان we can balance this concentration اللي هو الملح والمي. okay so basically this is what happened إنه نحن عندنا very high albumin concentration هون، very high concentration of solutes, very high osmolarity. what we are going to do is pull in the water back inside the intravascular space علشان we can make this concentration balanced والosmolarity balanced. فشو صار عندنا inflow inside the vessels and mainly it will exceed in the venous end. so always remember oncotic pressure with the three ends inflow and it would be mainly exceeding in the venous end with the keyword تبعنا اللي هي الألبومين. okay so going back to the question هل يا ترى صح وفي عنا كمان الليمفاتيك هيك بتكون مسؤولة عن if there is any excess fluid that is in the interstitial space رح يكون basically will be taken by the lymphatic system. والinterstitial space علشان everything is clear اللي هو between the cells. okay فالcapillary hydrostatic pressure always exceeds the osmotic pressure. let's think about this. هل يا ترى there is no accumulation in the interstitial space because of this؟ لو فعلا هذا الحكي صح what will happen is outflow والfluid will accumulate in the interstitial space وedema will happen. But plasma colloid osmotic pressure balances the capillary. Yes, this is correct. لهيك normally fluid accumulation does not happen. Fluid movement is controlled only by hydrostatic pressure. No, it's controlled by two opposite forces, one out, one in. Lymphatic drainage is inactive. لا, it's always active. أو دائما رح ناخد excess fluid inside the interstitial space. Moving on to the next question. نحن حكينا what is edema and why normally does not happen. Now we'll talk about why edema happens. يعني what are the causes of edema to happen. Which of the following is a cause of reduced plasma oncotic pressure leading to edema. هل يا ترى congestive heart failure, nephrotic syndrome, venous thrombosis, arteriolar dilation? What do you think is the right answer? okay so the right answer is basically nephrotic syndrome. فخلينا now let's discuss الأدما causes. why edema؟ نحن عنا 5 causes that was written inside the lecture بس I'm gonna talk يعني I'm gonna focus on the most important two اللي هو reduced plasma oncotic pressure increase hydrostatic pressure. okay so what will happen is reduced plasma oncotic pressure again. Plasma oncotic pressure اللي هو the one that will bring the fluid inflow. so if it was reduced يعني ما عندنا enough inflow what will happen إنه the fluid will accumulate in the interstitial space وedema will happen. why does this happen? always remember the keyword albumin. يا أما I don't have enough intake فبالتالي because مثلا of malnutrition so there is no enough intake of proteins malnutrition ممكن edema will happen. يا أما the production is not okay فبالتالي مين المسؤول عن البروتين production؟ الليفر. so if there is no enough production معناتها I don't have enough albumin وبالتالي ممكن يصير في عنا edema بتكون بالحالات patient who have liver cirrhosis يعني they have problem in the liver. يا أما إنه أنا مثلا okay I have good intake I have good production بس what happens is that the kidney will leak the albumin inside the urine فعم يصير في عنا leakage of the urine and this will be found in patient who have nephrotic syndrome. or I have a problem in the absorption in patient مثلا who have gastroenteropathy. okay فيا أما أنا عندي problem in the intake يا أما problem in the production يا أما problem of اللي هو elimination يا أما problem in the absorption. so remember the keyword albumin. okay فبالتالي ممكن patient يكون عنده nephrotic syndrome okay we think that okay this patient could have edema because عنده problem in the يعني albumin elimination فبالتالي ممكن يصير عنده edema. moving on to the increased hydrostatic pressure again if there is increase of hydrostatic pressure فبالتالي we have a lot of outflow صح ف this could lead to what? this could lead that the fluid will accumulate in the interstitial space. Why does this happen? Because of impaired venous return. مثلا think about this. Impaired venous return حتكون related to two cases. يا أما patient have congestive heart failure or thrombosis. So I need you to think that this is the heart and the heart is not pumping blood efficiently. Okay, so it will happen that the blood will start to back up على ال veins. تمام. What will happen that I will have here a lot of blood. Again, as I said, the hydrostatic pressure is the pressure that's produced by the blood inside the vessel. فراح نكون عندنا high hydrostatic pressure. If we have high hydrostatic pressure معناتها high outflow, and this leads to what? This leads to edema. هلا for the thrombosis I need you to think that this is the vein, okay? وهذا usually the flow تبع البلد. what will happen إنه ممكن يكون في عندي هون a thrombosis اللي هي a clot in the middle. فيلي راح يصير إنه basically كل البلد will start to get stuck here. again I have high blood in that side, I have high hydrostatic pressure, and this means I have high outflow and edema could happen. Okay, so we did understand reduced plasma oncotic pressure leads to edema. Why? Because مثلا بحالة nephrotic syndrome or liver cirrhosis or a patient who is يعني he's not taking enough proteins. Congestive heart failure is increasing hydrostatic pressure. Venous thrombosis is increasing hydrostatic pressure. And for arteriolar dilation, you basically I have vasodilation, high blood flow to this area. يعني بدل ما يكون عندي this is the artery راح يكون هيك، فبالتالي the flow will be higher, increasing the hydrostatic pressure. Moving on, I know what is edema. I know what are the causes of edema. Now let's talk about the different locations that edema could happen. In each location we have different name. Let's read the question together. A 50-year-old man with liver cirrhosis presents with abdominal swelling and history of bleeding from esophageal varices. On examination, his abdomen is distended with a fluid, and this is the picture that was mentioned. What is the name of the condition? Okay, what do you think is the right answer? Okay, perfect. Ascites. Yes, that's right. Bravo عليكم. So إذا you didn't know, it's fine, we'll learn these questions. It's very important to know that these questions are not to test your knowledge, بالعكس, it's to gain knowledge. It's to know why this is right and why this is wrong. So don't worry if you didn't catch يعني or answer properly. So it's fine, we are here to learn أكتر ما إنه we are here to يعني judge each other. Okay, so basically what's the name of this condition? As we said, in each different location edema happens, it have different name. فمثلا pulmonary edema, from the name usually يعني this edema happens in the lung. If it's hydrothorax, this edema happens in the pleural cavity. Ascites اللي هو basically his abdomen is distended, it happens in the peritoneal cavity. Okay, anasarca generalized everywhere. Let's go back and read the question. Okay, this patient عنده liver cirrhosis. As we said, I have problem when and the problem in the production of the albumin. So liver بيكون مسؤول عن هذا production. I have a problem in the production. فبالتالي عنده البيشنت راح يطلع عنده اللي هو edema وين بتكون بالperitoneal cavity اللي هو اسمها ascites. والesophageal varices is a complication from the liver cirrhosis. Okay guys, هلا يعني خلصنا. Now we talked about causes. حكينا عن الأديما causes. حكينا أصلا what's edema. edema abnormal accumulation of fluid in the interstitial space. وحكينا عن causes وحكينا عن different locations. هلا كمان في extra inside the lecture, but these are the most important. Now we'll talk about الأديماتيك fluid itself. يعني ممكن يكون الفلويد ممكن يكون transudative or exudative. From the word exudate, I need you to think about exit. يعني everything is exiting. And why does this exudative fluid happen? لأنه ممكن يكون في عندنا capillary wall damage مثل بالحالات اللي بتكون بالinflammation. So this is نقول this is the capillary wall. أنا صار عندي damage هون. So what will happen إنه everything will exit such as the proteins. So not only fluid, also proteins will exit. فرح يكون the fluid itself cloudy and it will be rich in protein. Okay, so once you see that the fluid is rich in protein, معناته was the cause inflammation. Okay, now for transudative fluid اللي هو basically disturbance in the Starling forces. I always remember the transudative in the word thick. راح يكون عندنا الهيدروستاتيك الأونكوتيك والليمفاتيك. أوكي. والترانسوديتيف fluid will be clear، يعني ما رح يكون في proteins. only it's responsible for the star lymphosis as we discussed. يعني هيكون يا أما أنا عندي decrease in the oncotic pressure اللي هو decrease in the oncotic pressure as we said the problem in the albumin كذا 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 كذا، or increase in the hydrostatic pressure اللي هو basically هيكون مثلا venous return impaired مثل congestive heart failure or thrombosis as we discussed، وهي very هيك summarized about whatever we discussed قبل اللي هو الأدمى causes. Moving on to the second important part in the lecture اللي هو thrombosis. Thrombosis basically is an inappropriate activation of clotting. The definition was in the lecture كان عبارة عن an abnormal activation of the hemostatic cascade. So what happens is that we have a very huge response to a tiny injury, or even there is no injury وفي عنا a thrombosis response اللي هو basically clot formation. Okay, so this hemostatic cascade will be activated يا in a very huge way أو even though we don't have anything, we don't have any injury, thrombosis happens or clot will be formed in a very easy way يعني علشان you understand it. So why thrombosis happen? What are the risk factors of thrombosis? So we have this keyword or this mnemonic اللي هي she. Okay, and this was taken from First Aid USMLE book. So basically حتى كانت بالlecture مكتوبة as virtuous triad. So S is for stasis, it stands for stasis اللي هو very reduced blood flow. The blood flow is slow معلق يعني. And when we see this متى بتصير هي الحالات؟ يا إما in post-operative patients or long drive or flight. Post-operative patients مثلا a patient who is hospitalized, he has done surgery for 2 to 3 weeks, he stayed in the hospital, so basically the patient is not moving a lot فبالتالي his blood flow will be reduced and thrombosis could happen. Or long drive or flight, again the patient is not moving, his legs are not moving فبالتالي يعني it's not moving too much فهذا الشيء بيؤدي لأنه blood flow will be reduced in the lower extremities و thrombosis could happen. Moving on to the H اللي هو عبارة عن hypercoagulability could be seen. hypercoagulability شو يعني؟ the blood is sticky. okay يعني it's not in a normal flow فبالتالي ممكن تكون in patients who are obese, pregnant ladies, or مثلا ممكن يكون in a primary cause اللي هو genetic such as factor 5 mutation. تمام. Moving on to the E اللي هو endothelial injury. مثلا we have an injury inside the blood vessel and it could be مثلا لما يكون patient عنده atherosclerosis or there is a trauma فبالتالي الانجري هاي will activate the hemostatic cascade. ممكن it will activate it in a very huge way فبالتالي هادشي بيؤدي لأنه يصير في عنا clot و clot will form. طيب basically when a clot forms ممكن يكون في عنا two types يا أما arterial thrombi يا أما venous thrombi. Very easy to differentiate between them. Arterial thrombi, we know that inside the artery the blood flow is very fast. okay طيب why does that happen؟ ممكن يكون in places where there is vessel bifurcation or there is atherosclerosis, and what we will be able to appreciate اللي هو line of Yazan اللي عبارة عن layered cake as you can see here. هون as you can see here. okay so we have dark area, pale area, dark area, pale area. So in the dark area we'll have red blood cells, in the pale area رح يكون في عنا fibrin and platelet. تمام. So this is for the arterial thrombi. The last one and the last thing that you need to know اللي هو non-occlusive. يعني non-occlusive it will not completely block the blood vessel. okay it will not completely block the artery. ليش؟ لأنه the blood flow is very fast. Comparing it to the venous thrombi, the blood flow will be very slow. تمام. فبالتالي هيكون completely occlusive, it will completely block the vein, وusually هيكون بالareas اللي هو there is very slow blood flow مثلا in deep leg veins. okay what is the fate of the thrombi؟ يا أما it will propagate يعني it will start to become مثلا لنقول this is the blood vessel and this is the thrombi. It will start to propagate to become bigger and bigger and bigger and bigger and completely block the blood vessel. if there is complete blockage of the blood vessel اللي رح يصير عنا يا أما stroke يا أما MI اللي هو myocardial infarction. فيعني this is why thrombosis is very risky لأنه الcomplication تبعها اللي هلأ رح نحكي عنها is very very risky. So it will happen إنه basically يا أما واحد it will propagate to become bigger and bigger بس بنفس البليس تبعها. يعني this is the blood vessel كانت هون صارت propagate صارت become bigger and bigger and bigger blockage will happen، أو ممكن it can dissolve by fibrinolytic activity، بتروح تماما. and this is لله الحمد يعني بفضل الله سبحانه وتعالى بيصير. يا أما it can eventually start to embolize، اللي هيصير في عنا embolus. okay طيب why does يعني شو يعني embolus؟ basically what will happen إنه اللي بيصير إنه مثلا think about this that this is the clot. okay a small part of it خلينا نرسمها. so this is the thrombi. okay فيلي رح يصير إنه I will have a very هيك small part that will block وهيك يصير في عنا. تمام. and then it will travel to somewhere else. okay and move on to مثلا somewhere else مثلا the lungs, the brain, and it will block an artery there which is a small artery or a small vein, and it will lead to MI or stroke as we said. فبالتالي هاد بنسميها الثرومبو embolism، اللي هي an embolism that's coming from a thrombi اللي هي clot. ممكن الامبوليس تكون anything، مثلا ممكن تكون air، ممكن تكون fat، ممكن تكون as we say the clot. so اللي رح يصير انه this thing مثلا fat it will travel and go somewhere else to block the vessel. okay فنحن remember that a thrombi is a clot forming. okay clot forming. بس an embolism اللي هو thrombi specifically thrombi embolism هي عبارة عن the clot is moving is traveling. تمام. okay guys, now moving on to a question based knowledge which is talking about a very important concept اللي حكينا عنها قبل شوي اللي هو embolism. okay so let's read the question then we'll discuss the answers inshallah. A 25-year-old man is admitted after a car accident with multiple long bone fracture. 2 days later he develops shortness of breath, confusion, and petechial rash on his chest. Which of the following is most likely the diagnosis? so basically نحن هون قاعدين عم يسألونا على ال diagnosis of this case. so what do you think is the answer? okay so the correct answer is B, fat embolism from bone marrow release. so basically as I said embolism هي عبارة عن anything. it can be a clot, it can be air, it can be fat that's going to move to somewhere else and block a blood vessel. تمام. so here we can appreciate from the scenario this patient have multiple long bone fractures. so it will happen because of this fracture the bone marrow will start to release the fat that is inside it and it will travel and block. اللي هون نحن we can see that the embolism site اللي صار بيكون this site يعني مثلا باللungs فصار عنده shortness of breath، صار في عنده pulmonary dysfunction، مثلا in the brain صار في عنده confusion. okay so we know from the scenario that اللي هو fracture I always link that with this اللي هو multiple long bone fractures with an F يساوي fat embolism. okay عشان ما يعني تتلخبطوا. كمان شغلة let's eliminate the other answers اللي هو مثلا pulmonary thromboembolism from DVT. okay this is يعني حرفيا you can cheat from the answer. so pulmonary thromboembolism so we have a thrombi okay that turned into embolism كما قلنا and it went to where to the lungs from the venous thrombosis. وقلنا شو الأهم شيء بالvenous thrombi اللي هو الستيسز. هل يا ترى المنرجع الكيس هل يا ترى البيشنت حكولنا انه he's hospitalized، حكولنا he has done operation؟ لا. فبالتالي we eliminate this. okay وبنعرف انه pulmonary thromboembolism 95% of pulmonary thromboembolism تجي from the DVT. okay moving on to this answer اللي هو air embolism from chest trauma. what is an air embolism أصلا؟ basically هو عبارة عن air bubbles بس لازم يكون يعني very huge more than 100 ml. تمام. so because of this air bubbles the blood vessel will be blocked. وغالبا ليش بتصير from chest trauma مثلا مثل bullet رصاصة يعني or a stab okay أو مثلا ممكن تكون because of vascular surgery بس remember a stab عبارة عن air embolism. كمان ممكن تكون systemic. هل يا ترى هاي الحالة هل يا ترى هي الكيس again when we go back to the scenario is it the case? no. so بالتالي it's not the correct answer. systemic embolism from atrial fibrillation هل يا ترى حكولنا البيشنت عنده atrial fibrillation anything was wrong with his heart? no, it was not mentioned أصلا. بالتالي so we know that multiple long bone fractures lead to fat embolism. we can see this from the يعني complications اللي صارت مع البيشنت. Moving on to the last thing that we need to focus on this lecture اللي هو this question. A 55-year-old man is admitted with higher fever, low blood pressure and confusion. He was warm skin and bounding pulse. Blood culture grows E. coli. Which type of shock is he experiencing? Cardiogenic, hypovolemic, septic or anaphylactic? What do you think? Okay, so the correct answer is septic. If you get this right, فبالتالي كفو عليكم. And if you get this wrong, it's fine. We are gaining this knowledge. Okay, so basically, which type of shock is this? أول شيء, let's know what is a shock. Shock عبارة عن there is not enough blood that is going to the tissues. the patient ممكن يصير في عنده hypotension, ممكن يصير في عنده tachycardia, ممكن يصير في عنده confusion. And as we can see here, كل shock يعني have a different cause. For example, cardiogenic shock. Cardiogenic shock اللي هو the heart is not pumping blood efficiently. اوكي فرح يحكوا لنا يعني البيشنت مثلا you have congestive heart failure فأكيد cardiogenic shock. Hypovolemic shock I have a very low blood volume ممكن تكون due to hemorrhage أو ممكن تكون due to burns. اللي بيصير إنه I have very very low blood volume يعني hemorrhage I'm losing blood basically, and in the burns I'm losing fluid. فالvolume of the blood will be lower than normal and this leads to shock. Okay, فكمان from the scenario we can know in septic shock دائما هتشوف مثلا بتلاقي blood culture grows E. coli. أنا بالseptic shock شو يعني I have infection أو مثلا ممكن يحكوا لنا البيشنت عنده very high white blood cells. اوكي ففوكس ودائما فوكس اوكي this patient هل عنده signs of اللي هو الشوك فبيحكوا له مثلا he have hypotension, he عنده tachycardia, البلس تبعه is bounding. anaphylactic is for allergy يعني ممكن كمان again in the scenario رح يغششوكم. Okay, now moving on to the second lecture, disease of the blood vessel. So basically we are going to do this in a question based plus explanation. So when we say the word arteriosclerosis, atherosclerosis, or arteriolosclerosis, maybe for 1 second we will say okay ممكن كلياتهم نفس الشيء, maybe they are all the same. But actually if we see this word يعني نحن we can cheat from the word itself, arteriosclerosis. Okay, so this means that the artery is hardening. It's very general. Which type of artery? We don't know. Very general. So it's describing a general disease that's getting the artery to become thicker, harder, and less elastic than normal. تمام? And we have two types. يا أما arteriolosclerosis, which means hardening of the arterioles and the small vessels. From the word also we can cheat. يا أما atherosclerosis اللي هو hardening due to an atheromatous plaque. What is atheromatous plaque? اللي هو عبارة عن lump of fat, هضبة من الدهون, such as this one. So what we can appreciate here that the lumen is getting smaller and the tunica intima is getting thicker. So the lumen is smaller but the tunica intima here is getting thicker. Why? Because the atheromatous plaque will build up in the tunica intima. Moving on, طيب, let's know the story of this atheromatous plaque يعني how it happens, how it build up. فنحن أول step عنا إياها endothelial injury. So this is the endothelial injury happened. Why this injury happened? Because we have risk factors. مثلا ممكن يكون non-modifiable or modifiable. Non-modifiable such as the family history, the male gender, so he's a male, we cannot change this. Modifiable means that basically something that we can't change. مثلا he's a smoker, so he asks the patient, can you please stop smoking? This is modifiable. مثلا he's eating a lot of fatty food, hyperlipidemia, so we can ask him, can you please eat healthy? Okay, so the first step اللي هو endothelial injury. This is the beginning, again the beginning of atheromatous plaque to happen. Endothelial injury, very very important, very 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 important. Okay, now for step 2 اللي هو what will happen that the endothelium will lose its function, so dysfunction. And I explained this in histology. Endothelium have a protection role واحد. 2 he have an antithrombogenic effect, so he يعمل a sign that not allowed anything to adhere here. So if there is an endothelial dysfunction, what will happen? Things will start to stick. مثلا monocyte will start to stick, leukocyte will start to stick, واللي رح يصير إنه LDL will enter, low density lipoprotein will start to enter. This is going on to the third step اللي هو once LDL enters. هلا نحن LDL ما عندنا مشاكل معه. Okay, it's fine. But once it enters, it will turn into villain. رح يتحول إلى شرير. فرح يصير اسمه oxidized LDL. okay. This oxidized LDL راح يتريجر لأنه صار شرير, so it will trigger our defense system, immune system. So مين اللي راح يجي المونوسايت will start to mature, turn into macrophages, and then it will start to eat up the oxidized LDL. So تأكل لتموت, حرفيا macrophages تأكل لتموت. So it will start to eat, to engulf until it will turn to foamy cells اللي هن عبارة عن macrophages filled of lipid. تمام. So هل يا ترى نقف هنا؟ we will stop here? No, we will continue. So these macrophages will start to call the immune system. So it will start to تعمل recruitment للimmune system. So cytokines will come, everything will come. رح نحاول ندافع بأقصى ما فينا من قوة. But actually الموضوع عم يزيد الطين بلة, يعني عم يقلب الموضوع علينا. And monocyte اللي هن foamy cells will start to release an inflammatory cytokines. Smooth cells will start to migrate from the tunica media into tunica intima. هيجي smooth muscle cells will start to be recruited, و eventually رح نشوف عنا collagen وعنا proliferation و extracellular matrix, and eventually what we are going to see هذا المنظر. This we will be able to appreciate the atheromatous plaque اللي هو the final step, plaque formation. رح نشوف السنتر اللي هو عبارة عن necrotic center filled of lipid, هيكون filled of foamy cells, هيكون filled of cholesterol crystals. رح نشوف a fibrous cap that is containing smooth muscles و plus inflammatory cells. Okay, so this leads that the tunica intima is getting thicker والlumen is getting smaller. هلا this is very important, يعني الأثيروماتوس plaque have a very important complications. واحد thrombosis. Okay, وهذا الحكي أصلا already نحن we mentioned it in the first lecture, but now I'm going to explain it أكتر. So basically هاي رسمتي المتواضعة جدا. I have this the artery, تمام, and this is the plaque, و this is the fibrous cap. What will happen إنه I have هيك a very little injury هون تخيلوا إنه أنا عندي little damage of the fibrous cap. So the things that are inside the fibrous cap will get exposed to the outside. فهذا الشيء راح trigger the homeostatic cascade. So thrombosis will happen, will clot will form, it will completely block the artery. Eventually as we said ممكن يصير في عنا MI or stroke حسب which type of artery. Second complication اللي هو الهemorrhage, يعني inside the plaque صارت جوا أنا عندي this is the plaque, inside the plaque I have the hemorrhage, it will start to expand, يعني هيك تصير expand completely block the artery. وعندنا third complication اللي هو atheroembolism. يا ترى from the word we can treat atheroembolism. So an embolism that is coming from the this atheromatous plaque, يعني it traveled somewhere else و block the artery. Aneurysm formation, this is very important, وكمان أنا عندي هون رسمة متواضعة جدا. Okay, so aneurysm هو عبارة عن شو؟ Basically let's understand this from the drawing. أنا عندي هون tunica intima, media و externa. Okay, these are the three layers of the blood vessel. So basically I have here what will happen إنه أنا عندي هون الأثيروماتوس plaque. Okay, imagine that because of this atheromatous plaque already the O2 will not be able to diffuse to the media, plus إنه الميديا will get recruited علشان تعملنا السموث muscles اللي هن الفايبرس كاب. Okay, this will lead that the wall will get very weak, وأنا already I have high يعني stress اللي هو blood flow plus the atheromatous plaque. So this leads that the يعني I have here inside the blood vessel inside the wall of the blood vessel هيكون في عندي هيك weakness, فبالتالي eventually it will bulge, يعني it will look like a balloon. Okay, and it will راح يصير في عنا localized dilation in this area, in the weak area للblood vessel. and what we care about اللي هو risk of rupture, يعني منخاف من هذا الموضوع. ممكن يكون on one side or on both sides of the wall. تمام. و eventually ممكن another complication اللي هو calcification, so the plaque will become harder. Okay, now moving on to the question based knowledge. I really like the question based knowledge and يعني الله يعينكم, بس يعني I hope you find it helpful. So reading the question, a 70-year-old man with a history of hypertension and heavy smoking comes to the clinic complaining of vague abdominal discomfort and occasional back pain. On physical examination, a pulsatile abdominal mass is palpated just below the umbilicus. Which of the following is most likely the diagnosis? It's asking about the diagnosis. Focus on the question. So what do you think is the answer? Okay, so the correct answer is abdominal aortic aneurysm. So الفكرة نحن already we talked about aneurysm. قلنا إنه الأنيوريزم ممكن تكون a complication جاي from the atherosclerosis، وهو عبارة عن bulging or ballooning or localized dilation للwall of the blood vessel due to these two important causes. Very important guys، كتير مهم. I have multiple causes بس these are the most two important. Why? Because common is important. So hypertension and atherosclerosis are the most two important causes for aneurysm to form. So basically نحن عنا different types of aneurysm. مثلا عنا الترو aneurysm اللي هي عبارة عن abdominal aortic aneurysm. اوكي، الترو aneurysm اللي هو the whole layer، كل اللاير راح تولد بلجات. تمام. now moving on رح نحكي عن باقي types، بس خلينا نركز. أول شي عرفنا ال most important types of aneurysm. تاني شي عرفنا إنه ال abdominal aortic aneurysm هي عبارة عن شو. let's go back and see the patient. اوكي، علشان تعرفوا الابدومينال aortic aneurysm حطيتها in this mnemonic اللي هو AAA. so you link الابدومينال aortic aneurysm with these three important keywords. this is the scenario اللي راح يجي عند البيشنت. أول شيء ال most important risk factor for abdominal aortic aneurysm اللي هو atherosclerosis. تاني شيء this is very important, this is a keyword abdominal mass that is pulsatile. ممكن يكون في عنده acute pain in the abdomen or in the back. Okay, so acute abdominal or back pain. Let's go back and read the scenario. We'll go back to the patient. أول شيء نحن we saw the keyword a pulsatile abdominal mass. تمام. you saw the keyword. Foreign you will suspect okay abdominal aortic aneurysm, but I need to make sure does he have the risk factors. Go back to the patient. أول شيء he's man. تاني شيء have a history of hypertension. ثالث شيء is a smoker. So you remember the risk factor of اللي هو اللي thromboembolism. Sorry, you remember risk factors of atherosclerosis اللي هن modifiable non-modifiable. فقلنا إنه هو hypertension, he's a smoker, he's a man, so this is non-modifiable risk factor. These are two modifiable risk factors, صح? all of these things will tell us okay this man عنده risk factor of getting atherosclerosis. We have the keyword of pulsatile abdominal mass, so this patient have abdominal aortic aneurysm. تمام. طيب moving on to the second question. A 56-year-old, he's a hypertensive man, presents to the emergency department with the sudden onset of severe tearing chest pain radiating to the back. Which of the following, again, is the most important risk factor for this condition? Focus on the question here. هون عم يسألكم على risk factor. So, what do you think is the answer? Okay. So, before we know the answer, what do you think is the case home? So the case is aortic dissection. Basically aortic dissection is a type of aneurysm اللي هو عبارة عن نحن عندنا الانيوريزم types إنه يا أما true aneurysm يا أما false يا أما dissection. تمام. dissection. فقلنا اللي true الexample تبعها إنه all the layers will be bulging out. كلها will be ballooning. كل layers of the blood vessel. and for base يعني for the true aneurysm قلنا التايب تبع الابdominal aortic aneurysm وقلنا الكيوردز وقلنا the most two important causes of aneurysm بشكل عام الهايبرتنشن والأثيروسكليروسيس. اوكي. فالدايسكشن عبارة عن شو؟ عبارة عن انه انا I have endothelial injury as you can appreciate here. what will happen انه the blood will start to accumulate between the two layers of the blood vessel. So the blood accumulate in the two layers of the blood vessel. It will start to expand. what will happen إنه ممكن يصير في عنا rupture. فيلي هيجي الرupture هيعطينا a sudden severe tearing chest pain that is radiating to the back. This is very important key words للأورtic dissection. very severe tearing chest pain suddenly happened radiating to the back. Think about aortic dissection. Go back to the patient. Does he have the most important risk factor? Yes, he's hypertensive. You know that this is aortic dissection. What's the most important risk factor? It is hypertension. Why it's not atherosclerosis? لأنه atherosclerosis أكتر related to abdominal aortic aneurysm. And as I said, A for the most important cause. هلا this is the last important part in the lecture اللي هو hypertension. We know what's hypertension. We know that it is resist elevation of the blood pressure. بس أنا I'm not going to discuss رح focus on the pathology point of view what's really important لأنه my friend Jenan إن شاء الله will discuss this in her part. فنحن عنا هون عم يحكوا لنا على the blood vessel how it will be present when a patient have hypertension, especially اللي هن arteriolo اللي هن ده يعني the small blood vessels الارتريولز. So we have three types: hyaline, hyperplastic, necrotizing. هلا هون يعني في عنا keywords كل وحدة لها its own keywords. الهايلاين غالبا it will appear in the patient who have benign hypertension, especially in the patient who يعني elderly patient, the diabetic patients will have benign hypertension, not very severe elevation. You think about hyaline arteriosclerosis. كمان إذا كانوا كريمين in the question they will give you extra keyword لأنه hyaline arteriosclerosis leads to benign nephrosclerosis اللي هو basically the blood vessels of the kidneys they will get smaller. Both kidneys symmetrically they will get smaller and smaller. This is a keyword that you will find it in the question إذا كانوا كريمين. بس يعني وحتى in the picture you can see that it contains pink hyaline wall. Okay, so hyaline arteriosclerosis from the name. Moving on to the second one اللي هو hyperplastic. الhypertension هيكون severe ورح نشوف onion skin lesions ويكون في عندك centric thickening. Okay, concentric thickening. يعني بالهايبربلاستيك see that hypertension is it severe ولا لا، وهل لو كانوا كمان كريمين ممكن يحكوا لنا انه في عنا onion skin lesions. So this is a keyword that we have hyperplastic arteriosclerosis. Necrotizing arteriolitis, this is the most severe case. هيكون في عنا very 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 high blood pressure، رح يكون في عنا malignant hypertension، رح يكون more 100 وأكتر. و what we will eventually see اللي هو fibrinoid necrosis، وأكتر شيء will affect the kidneys. Okay. Now this question أول question that we will apply the knowledge اللي حكيناها قبل شوي. Now I'm gonna read the question. A 45-year-old man presents with acute renal failure. His blood pressure is 250 over 125 millimeter mercury. Kidney biopsy shows fibrinoid necrosis of arterioles with vascular lesions. And the fibrinoid necrosis of arterioles will be kidneys. Which vascular lesions is most likely to be present? What do you think? Okay, so the correct answer is necrotizing arteriolitis. برافو عليكم. So we have very high blood pressure في عنا fibrinoid necrosis وموجودة بالkidneys. This is a keyword. Now the last part اللي هو immunology. The immunology lecture is very easy. You should focus on the first part اللي هن first 17 slides. Very 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 important. تمام. بس I'm gonna talk about the second part اللي هو atherosclerosis لأنه it's related to what I explained هلا. basically الاتيروسكليروسيس as a definition هي عبارة عن inflammatory mechanism من immunology point of view. هي عبارة عن an inflammatory mechanism وبيصير في عنا lipid accumulation و thrombosis، واللي بيصير إنه because of the endothelial injury اللي صارت بالfirst step endothelial injury you remember صح؟ because of this صار في عنا an inflammatory response وبعدين بيتحول ل chronic inflammatory response. It will start by innate immunity and then it will follow by adaptive immunity. So بالinnate immunity بيسموها ال pro-inflammatory environment، يعني هيك هتجمع كل القصص تبع ال pro-inflammatory environment. as we said once the LDL will enter it will turn to villain فبصير عنا oxidized LDL. تمام. فالمونوسايت will mature to macrophages، فالمونوسايت رح تتحول ل macrophages by what? by the GM-CSF and the MCSF. فأنا كيف قلتها إنه المونوسايت turn into macro، يعني عم تتضخم وين؟ بالجم. you remember الجم و M. okay. So هي يعني in multiple answers you can remember that these two things will turn المونو to macro اللي هن maturing in the gem. تمام. moving on. أول ما ال LDL turn into oxidize الماكروفاجز فورا بتطلع أسنانها لتأكل اللي هن اسمهم ال scavenger receptors. and these scavenger receptors have names اللي هن أنا سميتهم scavenger receptor، فسميته سارة CD368. فسارة اوكي CD368 اللي هو الباسورد of the CD عشان هيك يلينكت. فباسically السكافنجر ريسبتور هن عبارة عن SRA and CD CD36 CD68. هدول one of the receptors يعني one of the scavenger receptors اللي هن that was mentioned in the lecture. okay. فحكينا أول شي what are the things that will turn monocyte to macrophages الجم والscavenger receptor. أول ما ال LDL turn into oxidized فورا الماكروفاجز بتطلع أسنانها و turn into scavenger وبتعطينا scavenger receptors that will يعني engulf الأكسدايز LDL. فهلا صارت عنا هاي اسمها foamy cells اللي هن macrophages filled with lipid. صارت اسمها foamy cells. فقلنا هل تقف هنا؟ لا. it will start to release inflammatory cytokines such as interleukin 1B and this interleukin 1B رح يكون هدفه مين؟ السموث muscles. فالinterleukin 1B will let the smooth muscle secrete interleukin 6 which will go to the liver وراح يعني يعطينا مثل هيك innate immunity. هلا the thing is that هون atherosclerosis initiation it did initiate صار في عنا a little bit of initiation pro-inflammatory environment. فرح يكون عندها two fate يا اما رح يصير في عنا progression or regression. يا اما it will become bigger inflammatory will persist والplaque will become larger more fibrotic more necrotic and eventually it will obstruct the blood flow or regression. وهذا بصير بفضل الله سبحانه وتعالى. How does the regression happen? Basically البطل هيكون عندنا ال HDL will start to go to the foamy cells take the cholesterol from the foamy cells and then eventually macrophages will start to eat cellular diapers by a thing that's called atheroscytes. Atheroscytes هو cleaning the area basically taking any هيك أوساخ and this will lead إنه هاي البليك start to get smaller and smaller and reduced until يعني it will be هيك إنه التشو will start to heal eventually. تمام. فيا أما regression يا أما progression مين المين player عنا ال HDL regression. Now for adaptive immunity is very easy واللي بتختلف عنه بالinnate immunity إنه adaptive immunity will call the T cells. The T cells will give us CD4 CD8. okay. CD4 هيعطونا T helper cells. فال T helper cells هيكونوا مسؤولين عن أشياء معينة بس أنا I need you to know that بالinnate it's actually doing the inflammation بس بالadaptive is stabilizing the plaque. okay. فهون I'm doing the plaque بس أما هون أنا I'm stabilizing it by the T helper cells. فكل T helper cells مثل was mentioned here it have its own role. know this read this but I need you to focus on the T helper 17 cells. They are responsible for making the plaque stability أعلى. Plus, very important to know that all of these will be regulated by the Treg cells اللي هنا هيعطونا interleukin 10 and TGFB which is responsible for breaking this. So these Treg رح يكون مسؤول عن breaking all of this cycle and eventually making the inflammation أقل or doing a regression. okay. I know these two important points. I'm done with my explanation. I hope it's beneficial for immunology. Guys, make sure that you read the first 17 slides. It's very important in the exam. وإن شاء الله يا رب يعني هيك تكونوا استفدتوا وتذكرونا بدعوة حلوة. السلام عليكم ورحمة الله.
Okay, so moving on to the last disciplines that we're going to be talking about for week 1 and 2. I'll be covering pharmacology, hospital, and towards the end, I'll be going over a few concepts in psychology. And starting with pharmacology, regarding antihypertensive drugs, they are a very large group of drugs. You have a number of different classifications. As you can see, honey, you've got around 6 different groups, all with different mechanisms and different ways of working. And this is because hypertension is not a disease that affects a very specific or a very narrow group of people. Hypertension is it's a disease that can affect many different people from different ages, different ethnicities, different backgrounds. And so this means that we have a lot of different circumstances and contraindications depending on the person. So this is why you'll see that there are multiple different groups. Some are contraindicated in certain people and others are not. So before we start talking about the drugs and the different types, there's general terms to understand and general concepts to understand that have been brushed upon in physiology, but just to brush upon them quicker in a pharmacological stand of view. I will show you have 3 terminologies that are important when it comes to the function of the cardiovascular system. أول شيء عندنا the inotropic effect. The inotropic effect, when I say the word inotropicity, I mean the contraction of the heart, how strong the heart is contracting. There are certain agents that have positive inotropic effect and negative inotropic effect. And regarding chronotropic effect, I'm talking about the heart rate, so speeding up the firing rate of the SA node. آخر شيء we have the dromotropic effect, and this has to do with the conduction. So mainly we're talking about the AV node. So inotropic is the contraction, chronotropic is the heart rate, and dromotropic is the conduction. Now, when it comes to blood pressure, we have baroreceptors, which are the mechanoreceptors that are present that mainly they're mainly going to control blood pressure. When they sense blood pressure can either be maintained as a short-term regulation or a long-term regulation. A short-term regulation is normally through your sympathetic nervous system, in which any change in the firing rate, being an high or higher rate of firing rate, meaning you have hypertension, or slower rate, meaning you have hypotension, will cause the sympathetic nervous system to stimulate a reaction. The long-term regulation is through the kidney. Now, there are multiple different things that will stimulate the kidney to release renin, including the sympathetic nervous system itself, or decreased blood flow to the kidney, or decreased blood pressure where you have decreased sodium that can be sensed by the juxtaglomerular cells, and then ultimately releasing renin. Now, coming to the general effect and the general sort of mechanism that it works, because if I do explain this, it'll be easier for you to understand the point of view of the drugs and why and how these drugs work in different ways. If the blood pressure was to decrease, your sympathetic rate or your sympathetic activity will increase. So you're going to have an increase in mainly the beta and the alpha. The alpha will mainly go on your blood vessels to constrict the blood vessels, increasing the venous return and increasing the blood pressure by increasing the peripheral pressure or the peripheral resistance. The beta 1 is mainly located on the heart and on the kidney. On the heart, we're going to increase the cardiac output, and this will increase the blood pressure. On the kidneys, this will cause renin release. Other than the fact that the sympathetic nervous system will increase renin release, you'll also have the low blood pressure and the low blood flow to the kidney, causing the renin to be released. So this is the sympathetic short term that can only maintain and can only correct blood pressure for a short amount of time. The main control comes from the kidneys, in which the kidneys are supposed to release renin. Renin will take angiotensinogen, which is released from the liver, and break it into angiotensin 1. Angiotensin 1 will then be converted to the active form, which is angiotensin 2, through ACE, which is the angiotensin converting enzyme, which is released from the lungs. Angiotensin 2 can either directly go and bind on its receptors and have vasoconstricting actions, or it can go and affect the adrenal glands and release aldosterone. Aldosterone, in turn, will go back to the kidney and cause an increase in sodium and water reabsorption to increase the reabsorption, to increase the volume. Again, remember, renin is being released when you're having a drop in blood pressure or a drop in volume. So you need something to increase the pressure and to increase the volume. So either through vasoconstriction or through reabsorption. Something important about aldosterone, which can very much help when you're talking about an increase or a decrease in aldosterone, is the effect that it has on potassium. It increases sodium and water reabsorption and in turn secretes potassium. So this is important when we're talking about drugs that might affect this pathway or certain diseases that might increase aldosterone or decrease aldosterone. Now, antihypertensives, depending on their usage, we classify them, and we'll cover this more in hospital, but we do classify them as first-line treatment and as second-line treatment. Part of your first line, we have 3 main drugs. We refer to them as A, C, and D. So A is your ACE inhibitors, and then you're going to have C, which is your calcium channel blockers, and D are your diuretics. Certain resources might include beta blockers, but beta blockers are part of your second-line treatment, referring to your hospital lectures. Now let's start by covering the ACE inhibitors and all of the following drugs that work on the same pathway. Now again, the pathway, renin will be released from the kidney, converting angiotensinogen into angiotensin 1, then angiotensin 1 into angiotensin 2 via the ACE, or the angiotensin converting enzyme. And then angiotensin 2 is going to go and bind on its receptor to constrict blood vessels or release aldosterone to increase sodium and water reabsorption. Now, something to cover as well to understand the side effects and to understand the mechanism more is the fact that angiotensin converting enzyme, not only does it convert angiotensin 1 to angiotensin 2, but it also takes bradykinin, an inflammatory molecule, and breaks it into an into its inactive metabolites. bradykinin, if it accumulates in the body, if say for instance angiotensin is blocked and it's not there, which is the job of angiotensin converting enzyme, then these inactive metabolites will not be present and bradykinin will accumulate. Bradykinin will increase prostaglandin synthesis, which will cause vasodilation. Now, vasodilation is good because ultimately I'm going to have a decreased blood pressure, which is what I want when I'm giving an antihypertensive. But the negative side of bradykinin is the fact that it's an inflammatory molecule. So the inflammation is causing vasodilation and decreasing blood pressure, but at the same time, the inflammatory aspect of it will irritate the lungs and then cause the certain side effects that we see associated with ACE inhibitors. Okay, so ACE inhibitors, their role, they're your prills. The first drug that you should think of is the captopril, which is essentially like the first one. It will work to inhibit the conversion of angiotensin 1 to angiotensin 2. The second group that we have that is further higher up in the pathway, that is generally weaker and less potent and not commonly used, هو renin inhibitor. So it goes and directly inhibits renin. This is called Elshaeir. The thing is, most of the drugs that work really high up in the pathway are not very strong because your body will find other ways to ultimately propagate the reaction. So that's regarding renin inhibitors. The last thing that we have are your ARBs, which are the receptor blockers. They go directly inhibit the receptors, and in turn, the strength of them is very similar to the ACE inhibitors, though not as commonly used as ACE inhibitors. They do have less side effects. So those are the losartan and the valsartan. Let's start with the biggest group of them all, which is the ACE inhibitor, which is part of your first line treatment of hypertension. طالما it is inhibiting the ACE enzyme, so it will inhibit the conversion of angiotensin 1 to angiotensin 2, and then ultimately inhibit the product of aldosterone. So angiotensin 2 and aldosterone have decreased, so the vasoconstriction effects of angiotensin 2 is lost, so I'm going to have a decrease in the peripheral resistance, and aldosterone is also decreased, so the reabsorption of sodium and water is decreased. But other than the decrease in angiotensin and aldosterone, I will have an increase in bradykinin, and we just went over this. For this will propagate side effects. This will help in decreasing the peripheral resistance, but also at the same time, it will have negative effects. Going back to aldosterone, احنا حكينا aldosterone, the job of it is to cause sodium reabsorption and potassium secretion. So potassium is supposed to leave. طالما I've blocked this reaction, potassium will not be secreted and potassium will accumulate. So this explains the hyperkalemia that I might see. And we'll go to the side effects in a bit. So this is the general mechanism, and this is how it works. Coming to the drugs, أول شيء عندنا captopril. Captopril is a short-acting drug that you might need to administer 3 times a day, whereas the rest of the drugs you might administer 1 to 2 times. Once a day or twice a day, whereas captopril is around 3 times a day. It's a short-acting drug. It is not a prodrug, meaning you can administer the drug and على طول it causes the action without going to the liver and getting changed, which is the same as lisinopril. Now, why am I mentioning this? لأنه all of your ACE inhibitors, excluding these 2, are prodrugs. So they need to go into the liver to get hydrolyzed into their active form. This is like enalapril. Enalapril is an oral drug that gets converted into enalaprilate. You can give enalaprilate as itself as an active drug, but only through IV usage. So you usually use it in hypertensive crisis. So in a hypertensive emergency specifically, I will ultimately go for enalaprilate. Lisinopril is the lysine derivative of enalaprilate. So this is why it's not a prodrug. Fosinopril is the only one that's not eliminated by the kidney. The rest are all eliminated by the kidney. Why did I mention captopril has a sulfur hydride group or an SH group? This is because of the side effects that it might happen, or sometimes some of these side effects I can possibly prevent from happening if I pick another drug. فبدل مثلا I use a drug with SH in it, I'll go مثلا for another one that does not have. Okay? For the uses, the first one makes sense. حكينا إن it's for hypertension. Now for heart failure, the reason that it does that is because of a concept of afterload. Basically, again, it's working, ACE inhibitors are working to decrease peripheral resistance. طالما I've decreased peripheral resistance, I've dilated the blood vessels, Heart failure is the idea I cannot pump the heart cannot pump properly. So if I'm dilating the blood vessels, I'm also decreasing my afterload, for the heart is pumping against less pressure, so I can increase the ejection fraction to a certain degree. Regarding myocardial infarction, it has some effects in preventing apoptosis and some effects in preventing remodeling of the heart, so that's why it's used. You'll cover this more when you are in the weeks of the respected disease. But diabetic nephropathy, برضو similar concept of vasodilation and preventing remodeling and fibrosis. Coming to the side effects, you can use a mnemonic where you use the drug itself, captopril, and label it as such. أول شيء عندنا cough. Cough, by now you should have memorized your ACE inhibitors are associated with coughs. If the cough is really severe, you go for an ARB because of the bradykinin and the irritation to the lung. But then in the angioedema is a really severe problem. Ideally, you don't want to مثلا go to an ARB. You would ideally go for a calcium channel blocker, which is again a first-line drug, because it's a really severe problem. You worry about the person مثلا getting choked or whatever. But then in the proteinuria, then we have the taste and orthostatic hypotension are very transient, meaning they can happen for the beginning period of time and then they can go away. For taste, if it's very مثلا irritating to the patient, they can go for another drug that does not contain a sulfur hydride group. For orthostatic hypotension, what's recommended to start with a lower dose, to not have a really high dose to begin with. P stands for pregnancy, so the drug is contraindicated in pregnancy. All of the three drugs, or all of the three classes that we've spoken about, renin inhibitors, ACE inhibitors, and ARBs, are contraindicated in pregnancy. Then there is rash, an increase in potassium, and leukopenia or bone marrow suppression. So those are the side effects, and most of them make sense depending on either the bradykinin accumulation or the irritation that might be present due to the sulfur hydride, or مثلا aldosterone side effect with increased potassium. Now, coming to the idea of increased potassium, you cannot give a patient that is on his ACE inhibitors that you're decreasing aldosterone and increasing potassium. You cannot give them potassium-sparing diuretics or potassium supplements. Potassium-sparing diuretics are like your spironolactones. Ideally, you will not administer them together because this can cause hyperkalemia, and hyperkalemia can affect the heart in multiple different ways. It can cause arrhythmias and such problems. NSAIDs as well are problematic, usually because they are sort of minimizing the effect of the drugs. NSAIDs will decrease prostaglandin. The positive aspect of bradykinin the prostaglandin is going to cause vasodilation. So you're inhibiting the positive aspect and you're leaving bradykinin to irritate the lung. So ultimately, it's not the most ideal sort of combination. So this is regarding the ACE inhibitor. The other two groups, when we're talking about the renin-angiotensin-aldosterone system, are your ARBs, very similar to the ACE inhibitors in action. They don't necessarily affect bradykinin, so this is why they do not have cough, because they are teratogen. So ideally, you don't want to give them in pregnancy, similar to the renin inhibitors. They do cause diarrhea, cough, and angioedema, so they are not necessarily very commonly used, or they're not ideally replaceable with ACE inhibitors. Now, coming to your antiadrenergics, these are not used as first-line treatments, but I am just following your PowerPoint and how the doctor arranged them. And alpha blockers or beta blockers. Now, alpha blockers, we generally see they affect the vascular smooth muscles. So they mainly work by decreasing your blood pressure through decreasing peripheral resistance, because vasodilation. Beta blockers, they work by decreasing your heart rate. So that's negative chronotropic effect. Then they work by affecting the contraction, which is inotropic effect, and they do also affect the conduction, so they might have dromotropic effect. So they affect all aspects, the heart rate, the contraction, and the conduction. So they're different sources, different information, but they are not, according to your hospital lecture, they are not used as first-line treatment of hypertension. So this is just for you to know the adrenergic receptors. Beta-1 are on the heart and the kidneys. Beta blockers do initially work on the heart, but the main effect that we need from beta blockers is on the kidneys, which usually needs a few days to a few weeks to appear. Alpha receptors are mainly on the vasculature. So starting with beta blockers, as I said, it has negative inotropic effect on contraction, chronotropic on heart rate, and dromotropic on conduction. But the long-term desirable effect is the fact that it inhibits renin. Usually when we're talking about beta blockers, we can have them grouped as selective and non-selective. Ideally we want to block beta 1 and not beta 2. If you're taking your non-selective, the prototype drug, similar to how we said captopril is for the ACE inhibitors. In beta blockers, we're talking about propranolol. The suffix is olol for your beta blockers, but propranolol, this is your non-selective drug. Why is it not favorable to block beta 2 receptor? Because beta 2 is found on the lungs and in the liver. طالما I've blocked beta 2 receptors, I will no longer have the bronchodilation and vasodilation effect that beta 2 receptor offers. So I'm going to have bronchoconstriction. But this is why beta blockers, specifically the non-selective ones, are contraindicated in asthma because of the bronchoconstriction effects that they cause. Similarly, they do have effects on diabetic people because of their effect on the liver. يعني beta receptors are supposed to cause glycogenolysis. They break down glycogen. You inhibit that from happening, so you will not use them in people that have diabetes and problems in their insulin and problems in the diabetic people. Just for simplicity, selective beta blockers, you group them as A through M, with exception of nebivolol. Nebivolol is selective, though it is not in A through M. One important thing about it, it has nitric oxide action. So it's a very potent vasodilator. In non-selective beta blockers, you have N through Z, اللي هم whatever drugs you have, except cartulol. So A through M are selective, N through Z are non-selective, with exception of nebivolol as selective and cartulol as non-selective. Now, what are some of these side effects that we have? It makes sense لأنه you're looking at drugs that are decreasing heart rate, decreasing conduction. So you'll see مثلا إنه people with heart failure, ideally I will not give them. Though some specific types of heart failure, I will give certain types of beta blockers, and you'll know this more when you cover heart failure. Bradycardia, because it decreases the heart rate. Heart block. Obviously, it can cause hypotension, especially if you're giving it at a really high dose. We covered bronchial asthma and so on. Why did I skip benzymetal angina? Angina comes with different types, and a stable or unstable angina, and then you have your benzymetal or your vasospastic angina. Your vasospastic angina is basically an angina that is characterized by random constrictions and contractions of your blood vessels. So why am I not giving a beta blocker? Well, I didn't specify إنه مثلا non-selective. لأنه no matter how selective your beta blocker is, it will still have some effect on the beta 2 receptor. وإحنا طالما we're blocking beta 2 receptors, I'm losing vasodilation and I might cause vasoconstriction. Furthermore, على the angina that I have. So I will not use it. This is the same explanation for pheochromocytoma. Pheochromocytoma is a tumor where you have high release of catecholamines and you have vasoconstriction. Basically, you have sympathetic nervous system activation. So ideally, you don't want to, your alpha receptors are already activated. So you don't want to further that and worsen it. So ideally, you would administer a beta blocker with an alpha blocker or a drug that's already combined, زي labetalol. Now, an important thing about beta blocker, one more thing about them, is the fact that they cause rebound hypertension. So if you suddenly stop, it will cause rebound hypertension. So you need to stop the dose شوي شوي rather than suddenly stopping it. Then you have your alpha blockers. So your alpha receptors, both alpha 1 and alpha 2, are present in your heart to a certain degree. Your alpha 1 receptors, they're usually going to affect the inotropic effect, whereas alpha 2, they inhibit norepinephrine release. Now, the main problem with administering alpha blockers is the fact that, and this is seen in all vasodilators, basically as the generalized effect. When you vasodilate your blood vessels at a really extreme effect, you're going to have a reflex bilbaroreceptors, where it's trying to prevent hypotension from happening, so it causes reflex tachycardia. So this is why ideally you would administer vasodilator مع a beta blocker. المهم, they are used. You have your selective alpha 1 blockers that are usually used for management of hypertension, but again, the whole hypotensive response that is seen. Then you have the non-selective alpha blockers, which are very limited, and we usually only use them in pheochromocytoma. Now, other than pheochromocytoma and hypertension, we also have Raynaud's disease, which is basically a disease where any stimuli, any painful or cold stimuli, causes constriction of the alpha receptors, and it causes this sort of like lack of blood or cyanotic endings to be seen, so we can block the alpha receptors in treating them. Now, to just sum up the adrenergics, we have the adrenergic antagonists, which are combined alpha and beta. عندنا carvedilol and labetalol. So طالما I'm having alpha and beta effect, I will not see reflex tachycardia. Because the drug is not only an alpha or is not only a vasodilator. So I will not see reflex tachycardia. Now, labetalol or both of them are safe in pregnancy, which is important and most of the drugs that we've covered so far are not safe in pregnancy. Where do we usually use them? We usually use them in pheochromocytoma. So, most of the time, if a question is asking you about pheochromocytoma, you will likely see labetalol as an answer in your options. Also, remember, it's used as an IV drug. If we have an IV drug administered, then it's usually used in emergencies. This is similar to the ACE inhibitor, enalaprelate, where we said it can be given as enalapril, which is the oral prodrug form, or it can get activated and we can give it as IV administration for hypertensive emergencies زي اللابيتالول. Now, centrally acting sympatholytics اللي هو الclonidine, which essentially stimulates the presynaptic alpha-2 receptors and then ultimately preventing to lower the peripheral resistance and to lower blood pressure. But similar to your beta blockers, if stopped, it can cause rebound hypertension. And remember, methyldopa is safe in pregnancy. I've not included everything. I'm mainly focusing on the things that you're most likely to be asked about or things that are high yield. So methyldopa, labetalol are safe in pregnancy. Labetalol and enalaprelate are used as IV and they're used in hypertensive emergency. Labetalol, we use it in pheochromocytoma along with your non-selective alpha blockers, phenoxybenzamine and phentolamine. And clonidine, you can remember مع البيتا blocker, and it can cause rebound hypertension if suddenly stopped. Now, clonidine, similar to the group we're going to talk about هلا, we can use them in renal failure or when the kidney is damaged because they do not affect or they do not decrease renal blood flow. Similar to your calcium channel blockers. هلا calcium channel blockers, we can classify them as 3 groups اللي هو phenylalkylamines, benzothiazepines, and your dihydropyridines. Or for simplicity, the doctor is not going to ask you show your phenylalkylamine, though you can memorize. But for simplicity, usually this is how it's differentiated as non-dihydropyridines and dihydropyridines. Your non-dihydropyridines are cardioselective. They affect the heart muscle. They can affect your verapamil, for instance, it acts on all calcium channels. على عكس deltiazem, which is the benzothiazepine, it's more selective to the heart. So side effects are more associated with verapamil because of how broad it is. Whereas if I'm talking about dihydropyridines, زي nifedipine اللي هم your pines, I will most likely see it being vasoselective. So it will be acting like a vasodilator زي your alpha blockers. So reflex tachycardia is seen. But mainly used in hypertension. And we'll see this reflex tachycardia will cause it to be contraindicated in a certain case. This is regarding your dihydropyridines. And non-dihydropyridines, they're not just used in hypertension. They can be used as antiarrhythmics, specifically verapamil used in supraventricular tachycardia because of its broader aspect and its broader function. It's also a vasodilator, which is why we use them in hypertension. They can affect and they can do cardiac depressive actions and slow the AV node. Other than your calcium channel blockers, your non-dihydropyridines, and 2 groups or 2 drugs that can also slow down AV node. We usually do not like to administer them مع calcium channel blockers, your beta blockers, and your digoxin. Digoxin has positive inotropic effect. So it will increase contraction, it will increase the force of contraction, but it slows down the AV node conduction. So ideally, we don't want to administer them مع بعض. Again, your non-dihydropyridines, verapamil or deltiazem, are cardioselective, where dihydropyridines, basically you can say they're vasodilators and they're vasculoselective, with reflex tachycardia as a main side effect or as a main complication with them. And let's talk about the side effects to better understand the drugs. أول شيء we said, remember, verapamil was more effective على calcium channel blockers all around the body. So it can also affect the calcium channels on the بالGIT. If you're blocking them, that means they're not going to contract properly. You don't have calcium to enter, no contractions. You're going to slow down or immobilize the tract, this can cause constipation. برضه we said إنهم they're slowing the heart. Ultimately, drugs that are slowing the heart, زي beta blockers, ideally we don't want to give them with patients that have heart failure history, or we worry of it as a complication if someone is at risk of it. Disturbed conduction makes sense because we said it affects the AV node. Now, ischemic chest pain is in dihydropyridine. This is usually due to the reflex tachycardia. Usually people that are at higher risk of مثلا having angina or whatever, we do not want to administer nifedipine for them at all. يعني your cardioselective, we actually give them in cases of arrhythmias. But your vascular selective dihydropyridine calcium channel blockers are never given in the case of angina because of the reflex tachycardia that might cause chest pain. وبرضه vascular headache is usually seen in dihydropyridines. So those are the main two symptoms that are seen in dihydropyridines, whereas the rest are seen in the non-dihydropyridines. Drug interaction, we said beta blockers and digoxin, mainly because of their effect on the AV node. Beta blocker and verapamil are usually because of their effects مثلا to cause heart failure, to slow the heart rate, and so on. And grapefruit juice, which can increase the bioavailability of nifedipine. The last groups that we're going to be talking about are your vasodilators. Now, vasodilators, their main issue is the way that they work, and they generally decrease your peripheral resistance, causing reflex tachycardia. This low or decreased vascular resistance, not only will it necessitate a baroreceptor reflex, but it will also go to your kidneys. And your kidneys, because of the low pressure and the low resistance, the blood flow will decrease. There's no proper blood, the blood vessels are dilated, so the flow is going to go down, and so the kidneys are not receiving enough blood. So you'll activate your renin-angiotensin-aldosterone system, which will increase aldosterone, and it will ultimately cause sodium retention, increasing the volume, which is against what you want. And you're administering the vasodilator because someone has hypertension. So if the drug that you're given is increasing the reabsorption of water, that's only going to worsen the case. So with vasodilators, we will give a beta blocker to manage tachycardia and a diuretic to manage the sodium and water retention or reabsorption. I've not gone into too much details. They all work more or less in the same way على an ion level to increase potassium efflux and decrease calcium influx. What I'm focusing on mainly is the key important factors in each and every single drug. Why is it increasing potassium efflux? Potassium normally is found inside the cell. إذا طلعنا potassium برا, we're paralyzing the cell. Or you're decreasing calcium influx, the cell is not going to contract, برضو you're dilating the cell, dilating the blood vessel and causing vasodilation. So this is how more or less they're all working. What is important to know about them? Hydralazine, lupus-like syndrome, mainly butterfly rash. Minoxidil, hirsutism. وأصلا minoxidil is not very common. They're all not commonly used in hypertension, except some of them in emergencies. But minoxidil أصلا is used for hair growth. You can find it as ointment, and it can be used as for hair growth. Sodium nitroprusside, remember it as IV infusion, very important in hypertensive emergencies. زي الانالابريليت and your labetalol. بس مشكلة الsodium nitroprusside is the toxic agents that can happen when the drug is metabolized, اللي هو cyanide and thiocyanide. So we need to add sodium thiosulfate and hydroxycobamine to the management. What does furosemide mean? It's nothing but just بس diuretic. Furosemide is a loop diuretic. The most potent group of diuretics are your loop diuretics. So we just add them. It's just mentioned in the PowerPoint. But don't stress over it. It is just a diuretic. Diazoxide, again, given in emergencies, and it inhibits insulin release. Phenyldopamin, it works differently. It affects your dopamine receptors, causing vasodilation and natriuresis. And also remember, it increases intraocular pressure. But again, your other groups are more important than your vasodilators. But just remember certain key points about them. So now that we've covered pharma, it'll be easier to understand hospital and the management. This is probably the easiest hospital lecture you're going to cover. So let's get started. When it comes to hypertension, different guidelines define it as different ways. If we're following, the doctor will always focus on the guidelines that are here in the UAE. So usually for you to diagnose someone with hypertension, you need at least 2 readings that are at least 1 week apart. So you cannot have them in the same sitting. You do blood pressure مرتين, you have it's slightly elevated, so you diagnose them with hypertension. لازم they're twice, either مثلا he comes to the hospital twice and they're measured twice, or they can be done at home. If it's office-based, usually the blood pressure needs to be either systolic above 140 or diastolic above 90. If it is done at home, either a 24-hour ambulatory test, basically you put the machine, it reads on its own. It needs to be above 135 and above 80, or above 85. يعني blood pressure. When you talk about blood pressure, we don't mean both of them need to be high. So it could be isolated systolic, it could be isolated diastolic, or it could be both of them are elevated. Now, I'm not going to go over exactly how blood pressure is done because I'm assuming you guys know how it's done, but the patient needs to be sat upright. It's not correct to measure from over the clothes. And the patient shouldn't be talking while you're doing the test. They shouldn't have had caffeine before by 30 minutes, exercise, no smoking. Usually you'll measure from both sides and you take the higher one and so on and so forth. But just general ideas. Sometimes you might get a wrong reading and the patient does not have hypertension. It's just the way that you've done it is wrong. So hypertension, we can classify it based on the cause and based on what propagated the reason. It can either be as primary or essential, which is the most common type, or it could be secondary. The primary or essential, it's usually a bunch of risk factors that cause the patient to develop hypertension. Old age, more common in males, more common in people that are stressed, more common in smokers, and more common with family history and so on. So genetics and environmental factors that increase the risk. We cannot treat the cause, so we treat hypertension with the antihypertensive drugs we've just covered. But secondary, it has an actual cause. You have three most important causes. أول شيء عندنا primary hyperaldosteronism or Cushing's. Remember when I was saying when aldosterone becomes high, what happens is you're going to have hypokalemia and you're going to increase the secretion. So remember, let's say you get a case in the exam where he has hypertension, blah, 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 and he has hypokalemia. طالما hypokalemia, think of aldosterone. The second important cause is renal problems. Either you can have dysplasia, it's usually more common in kids, or you can have atherosclerosis causing hypertension. How can it happen in the kidneys? Usually if the afferent fibers are constricted with an atherosclerotic cell, مثلا the blood vessels are narrowed, for the blood flow is not going to be as smooth. For the kidneys are going to assume I'm not having any blood, معناته the rest of the body has no blood, so it will start to increase the renin-angiotensin system, which can cause hypertension. And the third most important or most common cause in secondary hypertension is the obstructive sleep apnea, which is usually due to episodes of hypoxia, activation of the sympathetic nervous system, and so on. That doesn't mean they're the only causes. Certain drugs can cause them and certain other factors can play a role, but these are your most important three causes. In secondary, you're treating the cause على عكس in primary or essential where you're treating the hypertension itself. Now, other than the cause of hypertension, we can classify hypertension as white coat and masked hypertension and isolated systolic, isolated diastolic. Isolated systolic is more associated with elderly, whereas diastolic is usually associated with alcoholics or obese people or people that smoke. White coat hypertension, this is usually false hypertension or not true hypertension because the patient can only have hypertension because they're stressed in the presence of a doctor or a nurse or someone wearing a white coat, or maybe just a hospital setting. So usually you'd ask them to take their blood pressure بالبيت. Masked hypertension العكس, and it's usually the more worrisome one, where at home they have hypertension, they come to the hospital, there's no hypertension. The last type that we can classify it as is resistant hypertension. Either it's controlled or uncontrolled. Uncontrolled, they're taking 3 antihypertensive drugs, including a diuretic, ولسه عندهم blood pressure high or hypertension. This is uncontrolled. Controlled resistant hypertension, they're taking 4 medications, but it's controlled. So either uncontrolled, 3 medications, or controlled with 4 medications. Okay, now moving on to hypertension in pregnancy. Hypertension could be chronic. معناته she's had hypertension before pregnancy or in the early 20 weeks. How do you make sure it's not gestational مثلا? The hypertension will continue 12 weeks after she's pregnant على الأقل, if not forever. So that's chronic hypertension. Then you have gestational hypertension, where it's happening after 20 weeks, where it can continue 6 weeks after pregnancy, but there's no proteinuria. This is very important, لأن if you start seeing proteinuria and edema, يعني يا إما تنتهي مع بعض يا إما واحدة, after 20 weeks, this is pre-eclampsia. And you worry about eclampsia where you're going to start to see fits and seizures, which is very dangerous, both على the mother and the child. And this is a very important concept. I remember we had a question in our year. So chronic, she's had hypertension before pregnancy, or she's developed it in the first 20 weeks. Gestational, after 20 weeks, no proteinuria. Pre-eclampsia, after 20 weeks, but she's having proteinuria or edema. And when you start to see fits and seizures, this is eclampsia. And regarding the grades, very important to know. Again, remember حكينا blood pressure, we start staging them. يعني you can have a high normal, but actual blood pressure is 140 and 90. Then you start jumping by 20. Stage 2 would be 160. For systolic, you jump by 20. 140, 160, and stage 3 is 180. For diastolic, you jump by 10, 90, 100, and 110. So 140 to 159 would be stage 1, then 160 to 179 is stage 2, and then above 180 is stage 3. For systolic. For diastolic, 90 to 99, 100 to 109 is stage 2, and above 110 is stage 3, which is what we call as hypertensive emergency or severe hypertension. Now, in hypertensive crisis, it's very important to look at the organ damage. If someone comes to the hospital with a blood pressure above 180 or above 110, from the first reading, you diagnose them with hypertension, and you look at the organ damage. You do a fundoscopy and you look at different aspects on the body. If there is organ damage, this is what we call as hypertensive emergency, and you administer IV drugs and put the patient in the hospital. If there's no organ damage, but it's still above 180, 110, we call it an urgency. For either urgency or emergency. Emergency, you have organ damage. If it's an urgency, you give oral medication. And these are some of your the drugs that we spoke about. يعني حكينا اللابيتالول مثلا, we spoke about الانalaprelate, and so on and so forth, nitroprusside. Those are all IV drugs that are given in the case of emergency. Other than that, in all stages of hypertension, when we start managing them, مثلا in stage 1, ideally you will not give medication. So this brings us to the bulk of your lecture. How are we managing hypertension? Hypertension usually is the person is coming to me with stage 1 hypertension. In most situations, I will not start with pharmacological management. I will start with non-pharmacological management. You'll ask the patient to lose weight. You'll ask the patient to go on DASH, which is a dietary approach to stop hypertension, reducing the sodium intake, increasing مثلا potassium intake, saturated fats like مثلا avocados and so on, decreasing smoking, all of the risk factors that we spoke about, مثلا caffeine intake, exercise, alcohol consumption, smoking, all of these risk factors that we spoke about, you want to reverse them, to manage the patient and to not start with drugs. You start with drugs either in stage 2 hypertension or stage 1 if the patient has another comorbidity, say diabetes or another cardiovascular disease, or your cardiovascular risk is more than 7.5%. I didn't include the link or so on. You can check them in your hospital PowerPoint, but it's essentially almost like a survey that the doctor fills out or the patient fills out. It gives a certain percentage. So if it's more than 7.5, is a list of stage 1, you still need to give them like pharmacological management. So everyone that's stage 2 starts with drugs, and stage 1 if there are other comorbidities. Ideally, we want to drop blood pressure below 140 and 90, depending on which one is high. But for people that are coming with stage 1, هم أصلا already their blood pressure is 140 or 90. Whereas if they're coming with stage 2, it's going to be 160 or 100. So these patients with stage 1, I'll drop them to 130 and 80. So 130 over 80. Within 3 months, you never suddenly drop blood pressure, especially if it's really high. First 9, again, we spoke about them, your ACE inhibitors, your diuretics, and your calcium channel blockers. You go based on almost like you're following a spectrum. أول شيء, you start off either or. You wait for a certain period. I think it's around 6 weeks. If the patient does not get better, you combine مثلا ACE inhibitors with diuretics, or ACE inhibitors مع calcium channel blockers, or diuretics with calcium channel blockers. You give the two. If the patient does not get better, you'll start to administer all three of them together, your first line. If برضو is not getting better, you start to think of your other drugs, مثلا your beta blockers, your vasodilators, alpha blockers, and so on. But as a first line treatment, you start off with one, and then you start to add عليهم 2, then 3, and then you add other drugs. And again, your aim is to drop blood pressure, ideally 140 to 90 if you don't have comorbidities, or if you've not started with this case. So this is a summarized explanation of the hospital lecture. Moving on to psychology, very simple lecture. It's just important to understand you can never look at a certain psychological illness or any illness in the body with a single approach. The biopsychosocial model is put to explain that everything in the body is linked to your brain, it's linked to the rest of your body, everything is linked in a way or another. Neglecting either or will cause worsening of symptoms, be it على a physiological disease or be it as a psychological illness. So I've not gone into all of the details in the lecture. I'm mainly going to focus on a lot of these are revisions. You've pretty much covered depression a few times, so by now you're supposed to be familiar with them. PTSD, you've also covered it. I think anxieties, maybe it's a new one, but I'm not sure. But I'm just going to highlight, you pretty much know all of these. But the important thing to know in depression, you need at least 5 of these symptoms for a period of 2 weeks. In PTSD, at least 1 month, and a person needs to have flashbacks. There's constant thoughts, there's constant worrying and memories and remembrance of the situation. Or a traumatic situation is, the definition of it has been changed. You cannot say you've heard someone say a story and then classify it as a traumatic situation. You should have lived through the situation for it to have caused you PTSD. So the definition and the diagnosis has changed. For anxiety, it could be psychological or it could be physical. Physical is like actual physical signs, a person has tachycardia or shortness of breath and so on. Psychological, it's things in your thoughts. So you're panicking about something, you're dreading something and so on. Generalized anxiety disorder, you need 6 months of at least 3 symptoms. So depression, 5 of the symptoms for 2 weeks, PTSD at least 1 month, and anxiety is for 6 months and you need 3 of these symptoms. So those are your main diseases. And you have other things in the PowerPoint and other scales, but you can just go through them. The most important part of this lecture is the medications. When it comes to diseases, diamond, we have CBT as our first line. You start with the cognitive behavioral therapy. Then you can give medications if CBT has not worked. What are some of the medications that we have? Your antidepressants and your antipsychotics. Antidepressants are cardioprotective. So when you see these drugs in the exam, make sure you recognize انهم هدول they are cardioprotective, more so than memorizing انهم they're SSRIs or they are antidepressants. Antipsychotics are the opposite. They're not cardioprotective, they are harmful. So we usually don't give them to a patient that has problems in their cardiovascular problems and so on. So if you see these drugs, they're not safe. If you see these drugs, they're safe. And that's pretty much the most important part of the lecture. And thank you so much for attending and listening. Hopefully it was a helpful session.